as well as through large droplet infection. Also a transplacental spread has been described. So these are the modes of transmission. The virus can enter through the respiratory tract, the mucous membranes, as eyes and mouth, as well as through broken skin as in case of bites. The unprotected contact with large respiratory droplets, the lesion material, the body fluids, and contaminated materials and surfaces can lead to the monkeypox infection. And what has been observed is that in the West, actually, this is seen mainly among the MSM. So the skin-to-skin contact is actually leading to the lesions in the anogenital region. So they are having only few lesions. So it can be mistaken as a sexually transmitted disease. And it is not actually a sexually transmitted disease, even though it is spreading among those communities. The reason is the close skin-to-skin contact, and it's not due to sexual transmission. Now, coming to the clinical features of monkeypox, initially the prodrome may last for around 5 days. The fever, along with lymphadenopathy, typically occurs with the fever onset. Preauricular, axillary, cervical, inguinal lymph nodes can be enlarged, be unilateral or bilateral enlargement. This feature is very important because lymphadenopathy is usually not seen with the close differentials of monkeypox, like say varicella infection or HFMD, measles, etc. The lymphadenopathy is not very common. So if you are having an epidemiological link with the rash and lymphadenopathy, you need to suspect monkeypox infection. So other constitutional features are headache, myalgia, fatigability, chills, or sweats. Now coming to the description of the rash. This usually begins within 1 to 3 days of fever onset, lasting for around 2 to 4 weeks. So this is another difference between monkeypox and is a close differential, that is varicella. Usually in varicella, the lesions won't last for around 2 to 4 weeks, whereas in monkeypox, the lesions can last for around 2 to 4 weeks. And the description of the lesions are also important. That is deep-seated, well-circumscribed lesions which often develop umbilication. So umbilication is usually not, that is a punctum or the dot is not usually seen in the lesions of varicella zoster. And these lesions could be painful and very pruritic. And the stages of the rash. Initially, the rash begins as an enanthem, that is in the tongue and mouth, you can get this ulcer-like thing. Then it progresses through the stages of macules, then papules, vesicles, pustular phase, and then goes for the crusting. So this is important. Usually in varicella zoster, we see the pleomorphic lesions. That is at the same stage, you may at the time of examination, you may see macules, pustules, vesicles, the crust like that. Whereas in monkeypox, it usually evolves through the stages of macular lesions, then papillary lesions, vesicles, pustular lesions, etc. So at one point of time, you will see only say papules are there, all the lesions will be in the stage of the papules. If vesicles are there, almost all the lesions will be vesicles. So pleomorphicity is usually not classically described in monkeypox, but now we have reports saying that in monkeypox also rarely you can see these pleomorphic rashes. And the area of involvement, around 98% cases, the face will be involved. 95% cases, palms and soles will be involved. This is also very important because in varicella zoster, usually the lesions are not seen in palms and soles. The oral mucous membrane involvement in around 70%, genitally involvement is there in 28%, conjunctival involvement 20%. So the sites are also very important. If the conjunctiva is involved, an ophthalmology consultation is necessary because this can actually progress to corneal lesions and can lead to blindness. And then this is actually the progression. By 3rd day, the lesions progress to the papules. By 4th to 5th day, the lesions becomes the vesicles. And then it might become filled with opaque fluid, become firm and deep-seated, then may become umbilicated and become confluent. And by the end of 2nd week, usually they dry up and crust, and the scab remain for a week before falling off. And ultimately, what is left behind is hyperpigmented atrophic scars or hypopigmented atrophic scars, or say patchy alopecia, hypertrophic skin scarring, etc. The notable predilection for palm and soles is characteristic of monkeypox. So basically, with regard to the rash, usually in the monkeypox, after fever, say around 1 to 3 days later, the rash develops and progress through the stages of initially enanthem. That is the lesions will occur in the mouth or the tongue, and then the lesions will occur in the face, and then in a centripetal fashion it occurs in the upper limb, the lower extremities, palms and soles, etc. So if you are seeing such lesions along with lymphadenopathy with an epidemiological link, think about monkeypox infection. And the predictors of progression of this lesion of the rash are the skin manifestation depends on the vaccination status. What do you mean by this vaccination status? The smallpox vaccine is actually protective, and around 85% protection against monkeypox is there for persons who have taken smallpox vaccines. Okay, smallpox vaccine. So the skin manifestation depends on the vaccination status, age, the nutritional status, the associated HIV status, and monkeypox chiefly occurs in communities where there is often a high background prevalence of malnutrition, parasitic infections, and other significant health compromising conditions, any of which could impact the prognosis of a patient with monkeypox. This actual statement is taken from the previous outbreaks which did occur in Africa. So basically, the progression of the lesion, the total number of lesions, etc., depends on the vaccination status, the nutrition status, and the HIV status of the host. The total lesion burden at the apex of rash can be very high, more than 500 lesions, or relatively less than 25 lesions. What we are seeing in the current outbreak is actually the number of lesions are actually very less. Okay, in our case also, we are having only less than 25 the lesions for the patient who has been diagnosed in Kerala. So these are the stages through which the rash progress. That is the macule, papule, vesicle, pustule, and the crusted lesions. Okay, so usually at one point of time, the lesions will be in a particular stage only. It won't be pleomorphic like in varicella zoster infection. So I'll take you through some images from CDC and all the classic lesions described in monkeypox. The firm, deep-seated, well-circumscribed, painful lesions which are umbilicated. You can see the lesions as well as the lesions in the, the palms. So usually the lesions in the palms are not well described in varicella zoster infection. So the lesions are usually the deep-seated, well circumscribed, painful, itchy, and sometimes umbilicated lesions. You can see the umbilicated lesions. These umbilicated lesions are usually not seen in varicella zoster. These are small lesions and often not distributed diffusely. The problem here is that this majority of the images are from the lesions in the face as well as the upper extremity, the trunk, etc. But what is being observed in Europe is that since it is being linked with the MSM activity and all, they're having more of anogenital lesions. That is the lesions inside the rectum like that. Patients might present with proctitis, tenesmus and all. So, and that is the reason why all the dermatologists must be aware of this thing. The patient might present with the lesion in the anogenital region and might get misdiagnosed as an STD. So if you look at the third image, this is the classical umbilicated lesion. Okay, so if you are seeing such lesion with an epidemiological link, you need to think about monkeypox infection, especially the lesion if the lesions are present in palms and soles also. And you can see inside the circle, a lesion with a punctum or a dot-like thing. Okay, so this dot-like thing is usually not seen in varicella zoster infection. Okay. And now coming to the inantha, the patients can have very painful lesions in the oral cavity as well as the lips, and sometimes the lips can be edematous as well. Yeah, in our patient, the patient has multiple ulcers in the lips as well as the inside in the side of the tongue and all. The lip was edematous, and the primary complaint the patient is having now is odynophagia. So the treatment for that is actually symptomatic only. So this is the time profile of the clinical features. So the incubation period is around 5 to 21 days. During that period, there is no symptom. And then there will be the febrile stage, which lasts for around 1 to 4 days, where the patient will develop fever, lymphadenopathy, headache, chills, fatigability, malaise, etc. And then for the stage of rash will develop, which might last for around, say, 2 to 4 weeks, followed by recovery. Now, coming to the current clinical presentation, which has been observed from around 6,000 cases, the clinical presentation of monkeypox cases associated with this outbreak has been atypical, as many cases in the newly affected areas are not presenting with the classically described clinical picture for monkeypox. That is, fever, swollen lymph nodes followed by the centrifugal rash. Among the cases who reported at least one symptom, 81% had the rash. There is widespread rash on the body, 50% present with fever and 40% present with genital rash. That is only around 50% of the cases had fever. Now, looking at the case demographics, around say 99%. This is the data from the cases from January 1st to July 4. Is from the WHO dashboard on monkeypox. You can see that around 99% of the cases are in males. Okay, and the average age of the reported cases is around 37 years. And among cases with reported sexual orientation, 60% identified as gay, bisexual, and other men who have sex with men. And 41% of cases with non-HIV status were positive for HIV. The healthcare-associated infections cannot be ruled out, and further investigation is ongoing to determine whether infection in healthcare workers was due to occupational exposure. As of now, out of the 6,000 cases, 25 cases have been reported in healthcare workers. So demographics from the USA, out of around 305 cases, the median age was around 36 years, and majority of the cases were in males. Now, coming to the differential diagnosis, the first differential that comes to our mind is actually varicella zoster, and how to differentiate varicella zoster from monkeypox we have discussed. The varicella zoster, you will be having a fast evolving rash. The rash will fast evolving rash, and will be a pleomorphic rash. Other DDs are disseminated herpes zoster, disseminated herpes simplex, measles, chancroid, secondary syphilis, hand, foot, and mouth disease, IMN, etc. And some of the differentiating features which might give a clue to us how to differentiate between monkeypox, chickenpox, and measles. So in monkeypox, usually the fever is there 1 to 3 days before onset of rash, just like in say chickenpox, where the rash will occur from day 1 or 2. Measles, usually the fever occurs around say 3 to 4 days prior to the onset of rash. And the distribution of rash is also important. So usually in chickenpox, the palms and soles are spared, and the lesions are more on the face as well as the trunk. Whereas in monkeypox, the palms and soles are involved in majority of the cases, and is more dense on face and the extremities. It's important. And lymphadenopathy is conspicuously absent in chickenpox as well as smallpox, whereas the lymphadenopathy, generalized lymphadenopathy, is usually present in monkeypox. And the mortality also, this is actually, these slides are from the previous outbreak. They show 10% of the mortality is in for monkeypox. With the current clade is actually less than 1%. Now, coming to the complications that we should be expecting, one is the secondary infections, then pneumonia, sepsis, encephalitis, and as previously discussed, if the lesions are there in the conjunctiva, the corneal involvement can occur, and this can lead to loss of vision. Now, coming to the case definition, so this is actually from the national guidelines. So we are dividing the cases into suspected cases, probable cases, and proven cases. A suspect is a person of any age having history of travel to affected countries within the last 21 days, presenting with an unexplained rash and one or more of the following signs or symptoms, which happen to be lymphadenopathy, fever, headache, body ache, or profound weakness. And probable case is actually a person meeting the case definition for a suspected case, clinically compatible illness, and has an epidemiological link, which means a prolonged face-to-face exposure, including healthcare workers without appropriate person protective equipment, direct physical contact with skin or skin lesions, including sexual contact, or contact with contaminated materials such as clothing, bedding, or utensils, is suggestive of a strong epidemiological link. So that is actually a suspected case with a very strong epidemiological link can be taken as a probable case. Confirmed case is a case which has been lab confirmed for monkeypox virus infection by detection of the unique sequences of viral DNA either by PCR or through sequencing. Now, looking at the risk factors for disease progression, that is the risk factors and clinical findings described as being associated with severe disease and poor outcomes. So there are certain patient groups at higher risk for severe disease or complications or likely to develop encephalitis or say pneumonia like that, which includes children less than 8 years, the pregnant women, then the immunosuppressed patients like those with HIV, those on immunosuppressants, etc. And in HIV also, only those patients with the poorly controlled disease are at risk. So data lacking patients with chronic skin conditions like atopic dermatitis, acute skin conditions like burns also are at higher risk of complications, especially due to bacterial superinfection. The clinical signs and symptoms which might suggest progression to complications are persistent nausea and vomiting, painful cervical lymphadenopathy causing dysphagia, poor oral intake, eye pain, vision abnormalities, hepatomegaly, sepsis, dehydration, pneumonia, ARDS, or confusion, lab anomalies, transaminitis, acute kidney injury, low albumin and elevated WBC and a low platelet count could be predictors of progression to severity. And based on the number of skin lesions, also there is a severity scoring. This is adopted from the smallpox era. So mild means less than 25 skin lesions, moderate is 25 to 99 skin lesions, severe is 100 to 250 skin lesions, and very severe is more than 250 skin lesions. And this is how once we are sending this, the specimens to NIV Pune, so what are specimens to be sent, etc., will be described in detail by Dr. Nihilesh. So the clinical specimens that are ideally to be sent are one nasopharyngeal swab, the oropharyngeal swab, 5 ml of blood in EDTA bottle, then 5 ml of urine, and most importantly, the multiple lesions, the skin lesions, they should be deroofed or the base should be scrapped using a double swab. It's a Dacron swab. And if there is a vesicle fluid aspirate, that can also be sent. And this will be subjected to the PCR for orthopox genus, and if positive, the PCR specific for monkeypox will be done, and later the sequencing will be done. Of the samples we have sent, we send around say 8 multiple samples. As the blood was positive, the urine was positive, the oropharyngeal swab was positive, the nasopharyngeal swab was positive, and the swabs from the skin lesions also were positive for monkeypox virus infection. Now, coming to the treatment, we know that in India, we don't have a specific treatment as such for monkeypox infection as of now. So the principles of management depends on the patient isolation, the protection of the compromised skin and mucous membranes, rehydration therapy, and nutrition support, symptom alleviation, and monitoring and treatment of complications. And where should we isolate a patient? Isolation of the patient should be in a room of the hospital or at home in a separate room with separate ventilation. This is from the national guideline. As of now, a plan is to isolate all the positive cases in hospital itself, and the patient should wear a triple layer mask, and the skin lesion should be covered to the best possible extent. Now, coming to the specific treatment, so in US as well as Europe, they have an emergency use authorization to use this antiviral, this tecovirimat, brincidofovir, and certain cases vaccine immune globulin, intravenous vaccine immune globulin. And they have 2 vaccines as well. These vaccines are used for the post-exposure prophylaxis for high-risk contacts who are at risk of progression to severe disease, and also in patients in the people who are working with these orthopox viruses, monkeypox viruses. Pre-exposure prophylaxis is also being given using these vaccines. And as a part of this outbreak containment strategy, they are using this ring vaccination policy also with these vaccines. And this drug tecovirimat, which is actually an inhibitor of the viral protein 37, which is very essential for this protein is essential for the development of the wrapping of the viral envelope. And tecovirimat is an inhibitor of that, which is approved surprisingly in July 2018 by US FDA. They had marketed it for, they had actually researched on it and discovered it and for smallpox. They thought that smallpox could be a bioterrorism threat, and this was approved in 2018. And now they are using the same drug for the monkeypox virus infection, especially in people who have a risk of progression to severe disease. And there was a head-to-head trial which was done in UK between tecovirimat and brincidofovir, where tecovirimat was found to be safer and more efficacious against monkeypox compared to brincidofovir, and the dosage is actually similar to that of linezolid, that is 600 milligram BD tecovirimat. This with regard to the 2 vaccines. This Jynneos is a live virus vaccine produced from the strain of modified vaccinia virus, and this ACAM is a live replicating vaccinia virus vaccine. Both these vaccines are not available in India. Now, the treatment considerations for monkeypox, this is from CDC. The people who should be considered for treatment following consultation with CDC is treatment with antivirals like tecovirimat. Persons with severe disease, that is those with hemorrhagic disease, confluent lesions, sepsis, encephalitis, or other conditions requiring hospitalization, or patients who may be at high risk of severe disease, that is those with immunocompromising conditions like HIV, AIDS, leukemia, lymphoma, malignancy. Then pediatric population, people less than 8 years of age, pregnant or breastfeeding women, or people with dermatitis or exfoliative skin conditions, etc. So these are the persons who are selected to be administered tecovirimat in USA. Now, coming to the very important aspect, that is IPC. We know that there is no airborne transmission. All the cases occurred following very, very close skin-to-skin contact and very, very close face-to-face contact. So what is to be adopted is contact precautions and droplet precautions. Hand hygiene, very important, respiratory hygiene, cough etiquette, patient placement. So PPE. So as per the national protocol, the PPE to be done before collecting specimens and when treating the patients are using the coveralls or gowns, the N95 mask, the double gloves and all. This is actually is very important. So there is no airborne transmission described with monkeypox. All the transmission occurred following prolonged face-to-face contact or skin-to-skin contact. This is important. And when you look at the transmission among the household contacts also, the secondary attack rate of monkeypox is actually 8% compared to smallpox, whose secondary attack rate was around 25 to 55%. Then other aspects in the hospital, we need to look at the safe injection, sharp injury prevention, environmental cleaning and disinfection, proper handling of laundry and linen. This is actually very important because as we have discussed, the linen might actually harbor this virus for a long period of time. And this virus can be, killed very easily. And so we need to take care of the laundry as well as linen very, very carefully. Decontamination and reprocessing of reusable patient care items and equipment is also important. Now, coming to the surveillance strategy that what we are supposed to adopt, that is isolate the cases to prevent further transmission, provide optimal care, identify and manage contacts, protect the frontline healthcare workers, effective control and preventive measures based on identified routes of transmission, that is a droplet as well as the contact transmission. And contact tracing, that's what we are doing now. A contact is defined as a person who is in the period, who in the patient who had contact with the source case of symptoms and ending when all scabs have fallen off, has had one or more of the following exposures with a probable or confirmed case of monkeypox as a face-to-face prolonged exposure without adequate PPE, direct physical contact including sexual contact, contact with contaminated materials such as clothing or bedding. And then contact monitoring, the contacts, we know the incubation period, maximum incubation period is 21 days, and we need to ensure that all these contacts are monitored for 21 days for the development of symptoms. As of now, the very close contacts are actually being quarantined in the state. Others are put on symptom surveillance for 21 days. The asymptomatic contacts should not donate blood, cells, tissue, organs, or semen while they are under surveillance. And if preschool children are under surveillance, it's better for them not to attend the class. And the important aspect is with regard to the healthcare workers who are contacts. So healthcare workers who have unprotected exposures to patients, that is highly unlikely now because now we are taking COVID-related precautions and all. So unprotected exposure is unlikely to occur for healthcare workers. So if such a thing has occurred to patients with monkeypox or possibly contaminated materials, they need not be excluded from work duty if they are asymptomatic, but they should undergo active surveillance for symptoms for 21 days. This is from the national guidelines. Now, actually, coming to the present case, so our patient is a 35-year-old male who flew from the Middle East, and patient had a very close contact with a suspected case of monkeypox while in the Middle East. And around 5 days later, around 7 days later, by around 5th of this month, patient developed fever with myalgia and fatigability, which lasted for around, say, 2 days. And then the patient developed oral lesions, followed by lesions in the skin. So you can see the lesions. So one lesion, this is the first image. You can see it is having a punctum sort of thing or a dot-like thing. So this is which is usually not seen in the varicella infection. And its major problem was you can see the edematous lips as well as the ulcers in the lip. So he's having difficulty in swallowing, and also was having secondary colonization with candida inside the mouth. And also see the lesions in the palms, and another lesions in the forehead also is having a black dot. That is the punctum is there. And inside the ear also you can see one lesion with a black dot. So these sort of lesions, these papular lesions with dot, these are not described in, usually not seen in varicella. And you can also see the multiple lesions in the oral cavity. That is then the tongue also, the multiple ulcers are there. And patient was having difficulty in swallowing, and follicular tonsillitis was there. Follicular tonsillitis also has been described in animal models of the monkeypox infection, and all his symptoms, the current symptoms are within relation to odinophagia, and he is being treated symptomatically, and he is actually clinically improving. So I'll take you through another case scenario. So when the patient presented to us, so he's actually a patient who is coming from Middle East with a possible, and he also had one lesion in the shaft of the penis. One lesion was there, and the total number of lesions are less than 25, and he had multiple enlarged lymph nodes in the neck as well as in the inguinal region. So we are having a patient who is coming from a Middle East, a country which has reported around, say an area which has reported around, say, 13 cases of monkeypox, and he gave history of a contact with suspected cases of monkeypox with these lesions, the lesions in the palms and soles, with lesions in the palms, lymphadenopathy, as well as the lesion, multiple lesions with the punctum like these things. So this actually qualifies as a case of a probable case of monkeypox, because a suspected contact is also there. And all the samples were sent to NIV, and all the samples turned out to be positive for monkeypox. Okay, so and then it became a confirmed case of monkeypox. And this patient will be isolated. And when will we take this patient out of isolation? It will be when all the lesions have crusted, and when the crust fall off and the skin starts growing back. That will be the time when we will stop isolation. We'll end with another case scenario. A 50-year-old man with history of recent international travel presents with fever, headache, cough, and rash. And this is a morphology of the rash. You can see that. You can see the macular lesions are there, the papular lesions are there, the vesicles are there, the pustules are there, the crust is also there. So this is actually the classical appearance of the varicella zoster. Okay. So because pleomorphic lesions are there. If it is a monkeypox, all the lesions are supposed to be in one stage only. If it is macules, everything will be macule. If it is a papule, everything will be papule. If it is vesicle, everything will be vesicle like that. And progresses from macule to papule to vesicle to pustule to crusting. Okay, in chickenpox, it will be a rapid progression, and there will be lesions in multiple stages. Okay, so this is varicella zoster. But as per our guidelines, if the patient is coming from a country where the monkeypox cases have been reported, any patient with rash, with fever, etc., qualifies to be a possible case of monkeypox. That is something we should keep in mind. Even though the morphology is classical of varicella zoster, if there is an epidemiology link or patient is coming from another country, we need to think about monkeypox also, because during the current outbreak, there are multiple atypical presentations of monkeypox also. In certain cases, lesions in multiple stages also has been described in monkeypox. So thank you very much for this opportunity. And usually lesions, cases like this, we are not seeing during the current outbreak in Europe and all, because all these images in the net are from the clade from Congo, that is Central African clade. So where the number of lesions are more than, say, 1,000 and all. Whereas the current clade, the West African clade, the lesions are much milder. The number of vesicles, pustules, etc., are also much less. So thank you very much. And Dr. Nikhilesh will talk on the samples to be collected and how it is to be transported, etc. Over to you, Nikhilesh.
Question answer session.
Madi.
Nikhilesh, Dr. Nikhilesh.
Oh, yes, ma'am. Ma'am, 1 minute. Screen share, yeah.
നമ്മുടെ Zoom 1000 expire 1000 കൂടുതൽ പാർട്ടിസിപ്പൻസ് വന്നതുകൊണ്ട് ലൈവ് സ്ട്രീമിംഗ് ചെയ്തു തുടങ്ങിയിട്ടുണ്ട്. അപ്പൊ യൂട്യൂബിൽ ലിങ്ക് നമ്മുടെ ചാറ്റിലുണ്ട്, എല്ലാവർക്കും അവൈലബിൾ ആണ്.
Screen കാണാനല്ലേ madam?
Then English, please go ahead.
Good afternoon, good evening, madam, and good evening all. I'll be talking about the sample collection and sample transportation as far as the monkeypox lab diagnosis is concerned. So as we know, as Arvind sir already said, the personnel who is collecting the sample is supposed to wear a personal protective equipment, as we are doing in COVID also. And the personnel is supposed to use coverall, gown, N95 mask, face shield, as well as safety goggles, as well as a double pair of gloves. And donning and doffing should be done as per the standard procedure. So basically, we are collecting samples from symptomatic cases. In the case of asymptomatic cases, we are supposed to follow them up till 21 days. And as and when the patient becomes symptomatic, we are supposed to collect the samples. So the sample collection is based on the type of sample to be collected is based on which phase the particular patient is currently on. So if the patient is in a rash phase, we are supposed to collect any of these samples, which includes the lesion fluid, lesion scab, lesion scraping, lesion roof, and EDTA blood, as well as blood in the plain vacutainer, and serum sample, throat swab and nasopharyngeal swab, as well as urine sample. I'll be going into the details of this after this. And if the patient is in the recovery phase, we can collect 4 to 5 ml of blood in vacutainer, SSGT tube, or 3 to 5 ml of urine. So if we are collecting sample from the patients having lesions, we are supposed to collect samples from multiple sites. As sir already mentioned, so in NIV lab, first they will be doing a PCR for orthopox virus genus, that which includes other cowpox, buffalopox, monkeypox, and camelpox viruses. And if at all it is positive, they will be going in for specific PCRs, conventional PCR specific for monkeypox, or real-time PCR detecting the monkeypox DNA. If it is negative, they'll rule out the monkeypox, and they will ask us for doing further investigation for other causes. And they'll also be sending the samples for virus isolation as well as NGS. So we are supposed to fill in this particular form, which is given by ICMR NIV, which has all the patient demographic details, as well as his clinical symptomatology, as well as any other complications which the patient is having. And the PDF of this form also they have shared actually. We are supposed to fill in all these columns, including whatever lab parameter in results which we already are having for this particular patient, for suspected patient. As far as samples are concerned, there are some special practical considerations. We'll be going to all those right now. In the case of nasopharyngeal swab as well as oropharyngeal swab, the most important thing is, unlike in the case of COVID, we are not supposed to transfer this NPS or oropharyngeal swab tubes into a tube containing VTM or any similar viral transport media. So basically, we should keep the swab into a screw-capped plain plastic tube, which is not having any kind of viral medium. In the case of a deviated septum or nasal blockage, in the case of nasopharyngeal swab, we are supposed to collect the swab from the other nostril also. Also, they are suggesting that as far as possible, we should collect a nasopharyngeal swab from both the nostrils. And we can keep both the nasopharyngeal swab as well as oropharyngeal swab in the same tube, as we were doing in the case of COVID in the initial phases. And we are supposed to keep the tube in an upright position in a stand. Usually laboratories will be having either a plastic stand or a metal stand will be there. So we can keep the tube in a stand in an upright position and send for packing. We are supposed to surface decontaminate the tube. Basically, the outer surface of the tube can be swiped using 2% Lysol or 0.5 to 1% sodium hypochlorite wipes. And I'm not going into details of the oropharyngeal swab collection procedure, but I'll only tell the important things. As we know, we are supposed to, not supposed to touch the sides of the buccal cavity when we are collecting the sample. We are supposed to collect a sample from tonsillar fossa, posterior pharynx, or in case of any ulceration or exudate or lesion is there, we can also collect a swab from there also in the case of oral swab. And we should not let the sterile swab touch the patient's tongue, gums, or the buccal cavity. And as I mentioned before, the swab should be kept into a screw capped plain plastic tube, which is not having any kind of viral transport media. That is the only change as far as the oral swab is concerned when compared to the COVID sample collection. In the case of nasopharyngeal swab, we already know the procedure of collecting a nasopharyngeal swab. Again, as I mentioned before, if we are suspecting a DNS or something, or any nasal blockage is there, we should collect swab from the other nostril also. If for practical purposes, as far as possible, we can collect nasopharyngeal swab from both the nostrils, so that the yield will be better. And the nasopharyngeal swab also should be kept into a screw-capped plain plastic tube, which is not having any kind of viral transport media. So the excess of the stick which is there, we can actually break it and recap the tube tightly. That is the most important thing. When we are keeping the swab into the plain tube, we should make sure that the cap of the tube is closed properly. Sometimes when the stick is too long and when the person who is collecting the sample is not bothered about breaking it and keeping it inside, the cap might not be closed properly, which might result in loss of the specimen. So basically, we should make sure that the plain plastic tube is properly screw capped before sending for packing. Also, the surface of the tube, that is a plain tube, that is basically the outer surface of the plain tube, should be properly wiped and surface decontaminated using a 2% Lysol or 0.5 to 1% sodium hypochlorite wipe. In the case of urine, we should collect 3 to 5 ml of midstream urine sample. So as in the case of urine culture and all, we are supposed to collect a midstream urine sample. So the initial stream of sample should be discarded. We should ask the patient to send us only the midstream urine sample. And the outer surface of the container in which the urine sample is taken should not be contaminated. Again, we should decontaminate the surface, basically the outer surface of the tube, using 2% Lysol or sodium hypochlorite. In the case of venous blood should be collected in both the plain vacutainer as well as the EDTA tube. The plain vacutainer blood is basically being used for serology testing. The EDTA tube blood is being used for PCR tests. So median cubital vein is the preferred vein for collecting venous blood. We should collect 5 ml of blood. Basically 5 ml of blood should be collected. And out of that, 3 ml should be in the yellow top SSGT, that is a plain vacutainer tube. This is for serology testing. And the 2 ml of the blood should be collected in EDTA tube. And the EDTA tube should be properly inverted and it should be mixed 4 to 5 times so that the additives which are there in the tubes are properly mixed and the sample quality is maintained. And again, we should surface decontaminate the SSGT, that is a plain vacutainer, as well as the EDTA tube. The outer surface of the EDTA tube should be surface contaminated with Lysol or sodium hypochlorite. Coming to the other lesions, basically when we are collecting samples from lesions, lesion roof, base scrapings, fluid and crust, or scab if present, all these sites we can actually collect the samples for laboratory diagnosis. And ideally we should collect multiple samples from multiple sites. So initially the skin should be sanitized with 80% alcohol wipes, and in the case of lesion roof, we should remove the lesion roof using a sterile scalpel or a plastic scraper. And the roof should be placed in a screw capped plain tube. In the case of a pustule or a vesicular fluid, we can use a intradermal syringe and the fluid can be aspirated, and again it can be transported in a fresh screw capped tube. In the case of scraping, we can use a polystyrene swab and the scraping shall be collected by gentle scraping, and again this swab should be transported in a fresh screw capped plain tube. In the case of a scab or a crust, it can also, again using a polystyrene swab, we can actually collect the swab or the crust, and it should also be put in a fresh screw capped plain tube. Now regarding sample transportation, once these samples are collected, immediately the samples should be kept in a 4° Celsius temperature so that the sample quality is not hampered. So after the collection of the samples, we should properly label the samples using a basically all these tubes which are in which the samples are there. We should seal the tube with a parafilm. And multiple lesion specimen, that is if the sample roof or the vesicular fluid, all those things are collected. All these individual multiple lesion specimens should be kept in separate plain tubes. As I already mentioned, plain tubes should only be used for collecting and transporting these specimens, these lesion specimens. And in the case of serum, it is ideal that we centrifuge the serum tube before shipment. And all the tubes should be wrapped in absorbent tissue. Usually what happens is that we usually take the primary container, properly seal the primary container, and we'll just keep it in the secondary container. Before that, we should make sure that the primary container is properly surrounded with proper adsorbent tissue or adsorbent cotton, so that even if any kind of leakage is happening, there is no harm. So basically, make sure that adsorbent tissue or adsorbent cotton or adsorbent material is properly placed along with the primary vial. All these samples for PCR testing to NIV Pune should only be transported in dry ice. That is the most important thing. But again, practical purposes, as we know, in some cases we might not be having dry ice. We might not be having access to dry ice. So in that case, for practical purposes, what we can do is, till the sample is transported to a facility where dry ice is there, and just before the sample is transported to that particular place with adequate dry ice, we can keep gel packs or normal ice packs in excess quantity, so that the whole sample specimen is actually having adequate number of normal ice till the sample reaches the facility with adequate quantity of dry ice. So basically what I'm trying to say is, if the dry ice is not there, we should not wait till the dry ice is procured into your place. Sometimes it might take more than 10 or 12 hours for you to get dry ice. In that scenario, for practical purposes, what we can do is, we can keep 20-25 normal ice pack or gel pack and wrap the sample and transport it to a facility where facility to pack the sample with dry ice is there. So this is the sample packing. As we know, 3-layer packing is needed, which we have already done in the case of COVID. So the primary vial should be properly, the cap of the primary vial should be properly sealed using a parafilm, so that there is no leakage. And this primary vial should be surrounded by adequate quantity of absorbent material or cotton, so that there is no, so that even if some leakage happens, there is no harm. And secondly, in the case of secondary container, we can either use a cryo container as a secondary container, or we can use a big centrifuge tube into which this primary vial can be kept. Always make sure that the mouth of the secondary container, in the case of a cryo box, this mouth of this cryo box should be properly sealed using a parafilm. That is also very important. And mouth of the centrifuge tube, if the centrifuge tube is used as a secondary container, the mouth of the centrifuge tube also should be properly sealed using parafilm. So this is what I already showed. We can either use a cryo box or a centrifuge tube. There is another possibility of using a secondary Ziploc pouch. So suppose we don't have a cryo box container or big centrifuge tube, we can use a secondary Ziploc pouch also. But in that case, make sure that the secondary Ziploc pouch is bigger than the first Ziploc pouch, which is used for covering the primary vial. If it is of the same size as this first Ziploc cover, we will not be able to seal the secondary Ziploc cover properly, which again will result in sample leakage. So always make sure that if Ziploc cover is used, make sure that the second Ziploc cover is of bigger size than the first Ziploc cover. And the mouth of the Ziploc cover should be properly sealed. And we can use actually rubber bands also if possible. And this is the outer container. So the secondary container or the secondary box is actually kept inside this thermocol box, which will be the outermost container. And we are supposed to pack dry ice in between the secondary container as well and the outer container. So basically in the space between the secondary container and the outer container, we are supposed to keep dry ice. Now there comes a question of keeping how much dry ice should be kept inside this container. Air cargo, usually this commercial private air cargo flights will only allow for 5 kg of dry ice. That is including the weight of the dry ice. Only 5 kg should be the maximum weight of the one single biological specimen box. So the thing is, if we are keeping 5 kg at the point of collection or at the point of packing, if you are keeping only 5 kg of ice, by the time it reaches the airport, which might be some 2 hours from your place, most probably this 5 kg of ice will be will turn up to be only of 3.5 kg or 4 kg. So make sure that usually dry ice, we are getting dry ice in 10 kilogram bars as well as 15 kilogram bars. So basically we will not get in 1 kg, 2 kg bars are not available currently. So whatever dry ice bar is available, if it is a 15 kg bar, we can actually split it into 2 if possible and then keep it inside this box. So it will be roughly 7 kg at the time of packing. By the time it reaches the airport, most probably it will be only 5 kg. So that weightage thing is taken care of. So ideally, we can keep up to 5 kg of dry ice should be there in this thing. And these are the documents we should be accompanying the sample by the time it reaches ICMR NIV lab. So there should be the packing list, that is the pro forma invoice should be there, and airway bill number, which will be the cargo consignment number, and another document which they will give from the courier, that flight agency people will be giving. So that also should be kept along with the requisition form. And the sender's address, consignee's address, and emergency contact number is very important. Sometimes if the sample is stuck up in some airport, they will always call the emergency contact number from where the sample was sent. So it is also important that this emergency contact number is also kept outside the thermocol box in a sealed polythene cover outside the cargo. Now the practical issues. Most of the time, as we have seen in COVID, what happens is the primary vial will be there, but it might be unsealed. That is, people will actually forget to put the parafilm over the mouth of the primary vial. That is very important. So the primary vial should be properly sealed. That is mandatory. And sometimes primary vial will be there, and secondary container will also be there, but there won't be enough adsorbent material covering the primary vial. That is one important issue, because sometimes if some breakage happens in the primary vial, the sample will be leaking. So if the absorbent material is there, the leak will not actually result in contaminating the whole cargo box. So it has actually happened. So it is also always make sure that the primary vial is properly sealed and enough absorbent material also kept in between the primary vial as well as the secondary vial. And if another important error which happens is the secondary Ziploc cover. Sometimes people use secondary Ziploc cover as the secondary container. So if secondary Ziploc cover is used, always make sure that the secondary Ziploc cover is bigger than the primary Ziploc cover, which is used for keeping the primary vial. Otherwise, the secondary Ziploc cover will not be properly sealed. And lack of inadequate ice pack is another issue. As I said, dry ice is mandatory. So dry ice should be kept in an adequate quantity. Make sure that at least 6 to 7 kg of dry ice is there inside the box. And the samples are being sent to ICMR and NIV Pune. Dr. Irma and Dr. Pragya, madam, are the point of contact there. The references are national guidelines for management of monkeypox and WHO document. Thank you, sir.
Thank you, Dr. Nikhilesh. Sir, madam, Rina madam.
Questions വന്നിട്ടുണ്ടായിരുന്നല്ലോ, അത്
ഒരുപാട് ക്വസ്റ്റ്യൻസ് ഉണ്ട്. അപ്പൊ ഞാൻ ആദ്യം ഒന്ന് വായിച്ചതിന് ശേഷം പോരെ സർ? അരവിന്ദ് സർ,
I think one aspect I did not mention came as one question from Lakshmi madam. There is the effect of monkeypox in pregnancy. So a small study done on 4 cases, it showed that there was 1 case of congenital monkeypox. There is a baby died, 2 cases of miscarriages, and 1 child had no issues. So it is a problem in pregnancy, madam. So out of 4 cases, 1 congenital monkeypox death, 2 miscarriages, and 1 normal baby.
ഞാൻ ക്വസ്റ്റ്യൻസ് വായിച്ചു തുടങ്ങട്ടെ സാറേ.
ആർക്കെങ്കിലും ചോദിക്കാനുണ്ടെങ്കിൽ
ഓക്കെ. ഡോക്ടർ ബെറ്റി, ശ്രീജിത്ത് അൺമ്യൂട്ട് ചെയ്യും പാർട്ടിസിപ്പൻസിന്.
സർ നമ്മൾ ജോയിൻ ചെയ്യാൻ ലേറ്റ് ആയി. ഇതിന്റെ വീഡിയോ, റെക്കോർഡഡ് വീഡിയോ യൂട്യൂബിലൊക്കെ അവൈലബിൾ ആവും സർ, പിന്നീട് നോക്കാൻ വേണ്ടിട്ട്.
അവൈലബിൾ ആയിരിക്കും,
ഓൾറെഡി അത് സ്ട്രീമിംഗ്
യൂട്യൂബിൽ അവൈലബിൾ ആയിട്ട് നമ്മൾ ലൈവ് സ്ട്രീമിംഗ് ചെയ്തിരുന്നു.
ഇടയ്ക്ക് ഒരുപാട് പാർട്ടിസിപ്പൻസിന് കേറാൻ ശ്രമിക്കുന്ന കണ്ടിട്ട് ലൈവ് സ്ട്രീം ചെയ്തിരുന്നു. അപ്പൊ അതിപ്പോഴും നടക്കുന്നുണ്ട്. ഇത് എഡിറ്റഡ് വീഡിയോ നാളെ യൂട്യൂബിൽ ഇടുകയും ചെയ്യും. Dr. Betty, please unmute and ask. Dr. Betty hand raise ചെയ്തിരിക്കുന്നു.
സർ ഗുഡ് ഈവനിങ് സാർ. നമുക്ക് ഈ സാമ്പിൾ കളക്ഷൻസിന്റെ ഇതിന് നമുക്ക് ഗവൺമെന്റിൽ നിന്ന് എന്തെങ്കിലും പ്രൈവറ്റ് ഹോസ്പിറ്റലിലേക്ക് എന്തെങ്കിലും സാമ്പിളിന്റെ ഇതിന് കളക്ഷന് അവർ വരും, അതെ നമ്മൾ കളക്ട് ചെയ്തിട്ട് ഗവൺമെന്റിലേക്ക് എത്തിച്ചാൽ വരാം? നമ്മുടെ നിഫോയുടെയും ഇതിന്റെയും മാതിരിയൊക്കെ തന്നെ ചെയ്യാൻ പറ്റുമോ?
ദിവ്യ, നിഖിലേഷ്.
മാഡം സാറേ, നമ്മളിപ്പോ ചെയ്യുന്ന ഡിസ്ട്രിക്ട് സർവൈലൻസ് ഓഫീസറിനെ ഇൻഫോം ചെയ്യാൻ വേണ്ടിയിട്ടാണ് പറയുന്നത്. ഇതിന് മാത്രമല്ല, അപ്പൊ ഗവൺമെന്റിലാരും വരും മാഡം? ദിവ്യ മാഡം, ഗവൺമെന്റിലാരും വരുമെന്ന് ചോദിച്ചാൽ സാമ്പിൾ കളക്ട് ചെയ്യാൻ വരുമെന്നാണോ ഉദ്ദേശിച്ചത്?
സ്റ്റേറ്റിന്റെ കേസ് ആയിട്ടാണ് നമ്മൾ കാണുന്നത്. അപ്പൊ ഡിസ്ട്രിക്ട് സർവൈലൻസ് ഓഫീസറിനെ അറിയിക്കും.
ഏതൊരു പ്രൈവറ്റ് ആശുപത്രിയിലാണെങ്കിലും അവർക്ക് ശരിക്കൊരു സിംറ്റമാറ്റിക് ആയിട്ടുള്ള ഒരു കേസ് വന്നു, ഹൈ സസ്പെക്ഷൻ ഉണ്ടെങ്കിൽ ഉടനെ തന്നെ നിങ്ങളുടെ ജില്ലാ സർവൈലൻസ് ഓഫീസറിനെ അറിയിക്കുക. ഇപ്പൊ നമ്മൾക്ക് അതാണ് അത് ചെയ്യാൻ പറ്റുള്ളൂ. കേസസ് കൂടുകയോ മറ്റോ ചെയ്യുന്ന ഒരു സാഹചര്യം വരികയാണെങ്കിൽ, അങ്ങനെ ഒരു വിദൂര സാധ്യത കാണുകയാണെങ്കിൽ അതനുസരിച്ച് പ്രോട്ടോകോളിൽ ചേഞ്ച് വരുന്നതനുസരിച്ച് ഞങ്ങൾ പ്രൈവറ്റ് ആശുപത്രികളെ അറിയിക്കും.
ഓക്കെ, താങ്ക് യു മാം. താങ്ക് യു. ഓക്കെ മാം.
വേറൊരു നമ്പരും ഹാൻഡ് റൈസ് ചെയ്ത് കാണുന്നുണ്ട്. എനിക്ക് തോന്നുന്നു ഹാൻഡ് റൈസ് ചെയ്യാതെ ഒരുപാട് പേര് ചോദ്യങ്ങൾ ചോദിക്കാനായിട്ട് കാത്തിരിക്കുന്നുണ്ടെങ്കിൽ ഓരോരുത്തരായിട്ട് ഒരു സമയത്ത് ഒന്നിൽ കൂടുതൽ ആൾക്കാർ അൺമ്യൂട്ട് ചെയ്യുകയാണെങ്കിൽ ജസ്റ്റ് ഒന്ന് മനസ്സിലാക്കി പിൻവാങ്ങിയാൽ മതിയാവും. ആർക്കെങ്കിലും ചോദിക്കണമെന്നുണ്ടെങ്കിൽ അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം. ഇതിൽ സ്ഥിരമായി വന്ന ക്വസ്റ്റ്യൻ സാർ, വാരിസെല്ല ഇൻഫെക്ഷൻ വാക്സിനേ അത് മുൻപുള്ള സ്മോൾ പോക്സ് വാക്സിനേഷനൊക്കെ എന്തെങ്കിലും പ്രൊട്ടക്ഷൻ ഉണ്ടോ എന്നുള്ള ചോദ്യം റിപ്പീറ്റഡ് ആയിട്ട് വന്നിരിക്കും.
Actually, the smallpox vaccine has 85% protection against monkeypox. Smallpox vaccine എടുത്ത ആൾക്കാർക്ക് the severity of disease, even if the disease monkeypox occurs, severity is likely to be actually very less. The efficacy is supposed to be 85%. And in US and Europe, they are using smallpox vaccine. That is, the ACAM 2000 is actually the smallpox vaccinia replication competent vaccine. Is used for post-exposure prophylaxis, and in people who are working with monkeypox virus, there is an expanded indication for using it as pre-exposure prophylaxis. So it is protective. 85% effectiveness is there against monkeypox also.
Dr. Ranjini CY, unmute ചെയ്ത് ചോദിക്കാവുന്നതാണ്.
Good evening, sir. It was a very nice presentation. I would like to know about the prophylaxis, like when the patient comes to the doctor, before we clinically suspect it, what is the prophylaxis or preemptive measures apart from, like, because currently nobody is wearing the PPE and sitting. So what are the precautions that the doctor can be taking?
Actually, the current outbreak of monkeypox is actually spreading through very, very close skin-to-skin contact and prolonged face-to-face exposure only, face-to-face contact only. So the usual that the N95 mask we are using and the standard precautions like 5 movements of hand hygiene should be enough to protect the healthcare workers. So even though out of the around 6,000 cases, 25 were reported in healthcare workers, now they are looking into whether they got it as an occupational means exposure or following, say, other exposures like that. So it requires prolonged skin-to-skin contact or prolonged face-to-face contact. Even in family contacts, the secondary attack rate is only 8%. So the usual things, the PPE kit as such is not needed. If you go through the guidelines, what is mentioned is we require face protection. That is, ideally an N95 mask and means the goggles or the face shield and the gloves and coveralls, bar, gown. So probably gown should be enough. And in our OPD and all, we will be using the N95 mask or the triple layer mask. And when we are touching any person, means if there are lesions in the skin or something like that, then we need to use the gloves, or glove is not available, we need to perform sanitation of the hands with chlorhexidine alcohol, etc., and that can kill the virus. And another thing is that what are the Madam asked about the post-exposure prophylaxis sort of thing, right? Okay.
Mute ആണ് രഞ്ജിനി madam.
Yes, sir. What is the post-exposure prophylaxis? Yeah.
Madam, as of now, in India, we don't have any post-exposure prophylaxis. So if there is a close contact with a proven or a suspected case of monkeypox, that person has to be in surveillance for 21 days. And then if the patient develops symptoms, then we will test and treat. That is the policy. We don't have any post-exposure prophylaxis as such in India. But in US and Europe, the post-exposure prophylaxis is being given using the smallpox vaccine. There are two vaccines for that. One is the Jynneos as well as the second is ACAM 2000. ACAM 2000 is actually the vaccinia. This is the smallpox vaccine, vaccinia virus replication competent vaccine. And that is given within, if the contact is within 14 days, that vaccine is being given, madam, as post-exposure prophylaxis. And since it is actually spreading in the MSM community in Europe and all, following these rave parties and all, and in certain cases, they are not able to identify the contact per se. So in such situations, they are even going for the ring vaccination is also being done using the ACAM 2000 vaccine or the Jynneos vaccine. So usually this ACAM 2000 is being used as a smallpox vaccine.
So one more question. There was a mention about the serological test. Is it available, or we have to send to NIV Pune also for that test?
Madam, as of now, the diagnosis is based on the orthopox PCR. If it is positive, then they will go for the monkeypox specific PCR, and then they will go for the sequencing to identify the clade like that. Okay. So we are not using the serological test, madam.
Fine. Thank you, sir.
And all the tests are being done only in NIV Pune as of now.
Will it cause scarring like smallpox?
Actually, means once the crust falls off, one slide was on that. It will lead to hyperpigmented atrophic scars or hypopigmented atrophic scars or alopecia. And if the lesions are, so numerous lesions are there in the face, it can even lead to facial contracture and all. But I think all these things are being described with regard to, if you're having, say, more than, say, 1,000 lesions and all, that's with the Central African clade.
Any other doctor, if you have any doubt, any other health staff who is having any doubt, please. Dr. Deepu Surendran, please go ahead. Dr. Vinod Paulos, sorry, Dr. Vinod Paulos in the hand raised. No, sir, you please go ahead.
Okay, then fine. Dr. Vinod Paulos, let him ask first, and I will ask later.
Vinod Paulos. Sir, unmute ചെയ്യാൻ കഴിയുന്നില്ലേ വിനോദ്? Everybody can unmute.
Yes, madam. Yeah. Yes, madam. I am now unmuted. Am I audible?
You are, sir. Please go ahead.
Yeah, thank you, sir. എനിക്ക് sir ഒന്ന് രണ്ട് കാര്യങ്ങൾ, ഒന്ന് റീഇൻഫെക്ഷൻ ഉണ്ടാവുമോ എന്നുള്ളതാണ്. പിന്നെ രണ്ടാമത്തത് ഫോർ തിയററ്റിക്കൽ സേക്ക് ലാക്ടേറ്റിംഗ് മദേഴ്സിന് ആർക്കെങ്കിലും വന്നു കഴിഞ്ഞാൽ അത് ലാക്ടേറ്റ് ചെയ്യാമോ? പിന്നെ മൂന്നാമത്തത് നമ്മളിവിടെ കണ്ടു ഒരു MSMലൊക്കെയാണ് ഉണ്ടാവുന്നുള്ളൂ. അപ്പം HIV പോസിറ്റീവ് ആയിട്ടുള്ളവർക്ക് ഇത് വന്നു കഴിഞ്ഞാൽ ഇതേപോലെ തന്നെയാണോ അതോ അവർക്ക് മോർബിഡിറ്റി കൂടുതലുണ്ടോ? ഇത് മൂന്നുമായിരുന്നു സാർ.
സാറിന് ഫസ്റ്റ് ക്വസ്റ്റ്യൻ ഒന്നും കൂടെ ഒന്ന് പറയാമോ സർ?
റീഇൻഫെക്ഷൻ ഉണ്ടാവാൻ സാധ്യതയുണ്ടോ? Yes, sir.
Sir, actually, for almost all the pox viruses, it confers lifelong immunity, like chickenpox or smallpox, like that. So monkeypox also should behave like that. Whether no infection due to one clade will protect against other clade at all, so we don't have any data on that. So we can hope that it will behave like other the pox virus infections, and because the mutability etc. is lesser, so probably might get lifelong this thing. Second is actually pregnancy and lactating. So whether if a lactating mother gets infected, you can lactate the baby. So because it spreads through close contact, I'm not really sure whether it will pass through the breast milk, that I don't know. But the close contact has to be avoided, because close contact with any lesion, suppose there is a lesion in the breast or something like that, definitely the child is likely to get infected. And if the less than 8 years, the outcome is not really good like in others, because now the patient can develop encephalitis and all. So theoretically, for all practical purposes, breastfeeding may be out of option, but whether it will pass in, through breast milk, I am not really sure. Regarding the third aspect in HIV, if the viral load is controlled and all, so the outcome should be good. But no data from Africa as well as WHO etc. shows that in HIV there is a risk of disease progression. And as you have rightly mentioned, since the spread is mainly among the MSM community in Europe and all, and definitely the HIV patients are at increased risk, and there is also increased risk of progression. But all the data saying that the severity is more in HIV comes from the African era. Probably they may not be virologically suppressed. If the patients are virologically suppressed with very, very good CD4 count, the outcome should be good, sir.
Yeah, thank you, sir.
Thank you.
Dr. Deepu Surendran, please.
Okay, thank you. Sir, one doubt is actually that you had already mentioned that the smallpox vaccination or history of smallpox gives an additional protection against, in fact, about 85% protection against the monkeypox. But majority of our population doesn't have any history of smallpox. I mean, in the below 50 age group, or even don't have the vaccination against smallpox. So in the context, I would like to know that especially in the pediatric age group, most of our children are vaccinated with varicella, against varicella. So will that vaccination against varicella or a history of varicella infection in the past would give them any sorts of protection as in the case of smallpox? Can you elaborate on that?
Actually, I don't know the answer to this question, sir. But with regard to, because the majority of the population below 50 years are susceptible to monkeypox, as you rightly said, should they be vaccinated with smallpox vaccine? My point will be that the smallpox vaccine is ACAM 2000 and all, the risk of myocarditis is around 5% per 1,000, right? That risk is definitely there. The current means, the outbreak of monkeypox, out of around 6,000 cases, the mortality 3 has occurred only in Africa and all, in Europe and developed nations, and probably in our healthcare system. So I think we'll be able to save all the patients with just supportive treatment. So that is what I really feel, sir. And regarding whether chickenpox will protect, a vaccine will protect against monkeypox, I really don't know.
Okay, suppose if do we have any anecdotal evidences or anything like that by if some of the parents might be anxious and be asking us, would it be better if we can protect the child with the immunoglobulin with varicella? So what we can say is that we don't have any evidence to say.
We don't have any evidence, sir. Actually, the immunoglobulin VIGIV is actually the vaccinia immunoglobulin for high risk patients. Means advised by USFDA, it's adopted by USFDA. The varicella immunoglobulin is not likely to work.
And also regarding the previous question regarding the recurrence of this monkeypox in varicella and all, in the case of immunosuppression, for example, uncontrolled diabetes, or in the case of HIV, since this virus is already in the dorsal ganglion, it may come out as a varicella, so it's not the varicella. In the ganglion wise, it may come out as a herpes zoster. So would this case also, in the case of monkeypox also, will that can happen?
Actually, even varicella gives lifelong protection only to 95%. 5% can still have a recurrence of varicella. Also, in patients who are heavily immunosuppressed with chemotherapeutic agents and T-cell depleting agents, also they can have varicella again. So, in such scenarios, probably we can have, probably it's likely to have monkeypox again. Such scenario, but those are rare occurrences.
Okay, sir. Thank you.
But there is always a risk because now we are having more and more therapies which can take away the entire T cells, especially adalimumab and all. So if your T cells and everything is lost, and if your rituximab, the B cells, everything will be lost. In such situations, we can expect anything like recurrence and all.
Okay. Thank you.
Actually, there are a few questions on pregnancy on each trimester. What is the effect, like varicella and all? If you can elaborate on that. There is also some questions regarding how is the surveillance? Are we going to check all the close contacts? How is the isolation like? Like, is it negative?
Okay, regarding the pregnancy part, the first trimester, second trimester, third trimester, like those things. Only data I am familiar with is what I already told. That is, in a study of 4 cases, one child developed congenital monkeypox and died. 2 mothers developed miscarriage, and 1 actually had a normal delivery with a normal child. That's the only thing which is available in up to date data. Regarding the trimester specific, I'm not really sure about. Definitely, the congenital will be likely to be more in the first trimester. That's all. Second, what is our surveillance strategy? As of now, the surveillance strategy of the state is that we have identified all the contacts, and all the high-risk contacts are being quarantined. There is another question whether quarantine is needed or should we go for symptom surveillance. As per the national guideline, actually, all the contacts the contacts which satisfy the definition should be put on symptom surveillance for 21 days. It's not quarantine. But since it is the first case in the state, the first case in the country, the RRT has decided to quarantine all the high-risk contacts for 21 days and test them only if they are having symptoms. The thing is that the majority of the contacts are likely to be in people who came through the flight and all. And those patients, as well as healthcare workers who are on 21-day surveillance, also are likely to develop fever, which could be due to COVID-19. That is also something that we need to consider and that we discuss in RRT. So if they develop fever, so they have to be checked for COVID-19 as well. And if they develop rash, definitely the samples will be sent for this thing to the NIV Pune for confirming monkeypox. That is the current strategy. The real high-risk contacts are quarantined. Others are being followed up for 21 days. That is the maximum incubation period for the onset of symptoms.
Dr. Narayanankutti, sir.
So good evening. I am from Palakkad, sir. Actually, I was unable to hear the proper discussion and because of some technical problem. My question is that is ART, antiretroviral treatment, is protective in this monkeypox cases, sir?
Actually, it's not, sir. It's not protective. It is not protective, sir.
Sir, is that all, or do you have some more questions?
Divya, there is a related question. Is a disease transmitted from close contact only, or should we be alarmed like COVID-19? We should not be alarmed like COVID-19 because this spreads only through very close skin-to-skin contact and through prolonged face-to-face contact. So the chance of transmission occurs only through very close skin-to-skin contact and through very close prolonged face-to-face contact. Does not spread like COVID-19.
Sir, there are a few questions regarding how to evaluate an rash similar rash without epidemiological link. There are patients and retropharyngeal abscess who are presenting to them with fever, with lymphadenopathy and all. Should they be suspected? They don't have any history of travel.
Actually, the key as far as monkeypox in the state is concerned is the epidemiological link. Because without that, no, the swollen nodes as well as the oral ulcers can occur in a lot of other conditions. So the epidemiological link has to be paramount. If you look at the case definition also, the possible case, the probable case, and all those things is very important. So epidemiological link is actually the paramount. Suppose you are seeing a patient with, you know, the classical lesion, like say a papillar lesion with punctum. All lesions are in the same stage. You are seeing lesions in the palms, and you are getting lymphadenopathy, the oral lesions and anogenital lesions, etc. But the patient is not giving any history of say contact with a suspect or a proven case of monkeypox and all. You need to go on asking the definite history. In such cases, definitely you can contact the state authorities. Today also, we got a concern like a patient is having, say, multiple lesions, is suggestive of varicella zoster. Should we be sending for monkeypox? Should not be sending for monkeypox, because as of now, we have only one case, and that is also an important case. So the epidemiological link is actually very, very, very important.
Sir, now coming to treatment protocols, whether we have some treatment protocol in writing, or what is the treatment protocol, whether we are having the drug tecovirimat with us in Kerala.
Actually, all of you should go through the national protocol really on the treatment of monkeypox. The treatment is basically the supportive treatment. So we don't have access to this antiviral drug tecovirimat, or we don't have access to the vaccines for the post-exposure and pre-exposure prophylaxis. We don't have access to. As of now, we are relying on the supportive treatment, which in the healthy people should be enough. In our case, in the current case, the patient, the main symptom as of now is the severe odonophagia. It was actually having difficulty in swallowing stuff and all. So the supportive treatment included, you know, a betadine gargle, say NSAIDs like that, and say some say vitamin C and all. And patient had, because of the extensive oral lesions, had colonization with candida. So we started the patient on fluconazole also, and probably means the counts were towards the higher side. A secondary bacterial infection, periodontitis was also suspected, and antibiotics were started. And patients are complaining of itching lesion. For that, no dermatology consultation was sought, and antihistamines were started like that. So the supportive treatment is what we can offer as of now. WHO is also recommending only supportive treatment. So in countries where you have access to tecovirimat and brincidofovir, this can be tried in patients who are likely to develop severe disease, like children less than 8 years of age, those who are immunocompromised like that, those with atopic dermatitis or the skin lesions and all. In such patients, no, they are using this antiviral drug, tecovirimat. Even in USA, they are having a shortage of this drug. Okay, so means, you know, India, I don't think that we'll be able to get tecovirimat. So vaccine also, we don't have any stock of these vaccines, Jynneos or CAM 2000.
There are some queries regarding whether the index case, our first case, is having a contact with a confirmed case of monkeypox, so that the epidemiological link is clear for us.
Actually, means our case had contact with suspected cases of monkeypox. Initially, he said it's a confirmed case, but then he said they suspected cases of monkeypox. Okay. Basically, any patient who is coming from abroad, he says that no, he had a very close contact with a person with the skin lesions or fever or something like that. Probably means our threshold of suspicion should be high, especially if he presents with the features that we have already discussed.
Nikhilesh, one question to you. Actually, do we have any right away serological test to diagnose monkeypox, or is that we are having sending all these samples to NIV Pune only?
No, ma'am, we are not having any commercial serological test for monkeypox as of now. And we are sending all the samples to NIV Pune, but as in the case of Nipah and maybe they might develop some kit, NIV might develop some in-house kit at some later point of time. So right now we are sending we are asking for the serological samples also to be sent to NIV Pune, maybe for storage. That's what. Yeah, we are not having any serological tests as of now. That is what I understand.
These are the questions which I got. Anybody, if having some queries, please go ahead. I think this is too early a session for all of us to have some queries.
Hello.
Hello.
Please.
Hello. I'm Dr. Ajit.
Parayyu, sir.
Okay. Okay. I have a question to Dr. Aravind, basically. Now, actually, we are having a small epidemic, I don't know whether you can call it epidemic, of hand, foot and mouth disease in India, especially this part of the world. And most of the lesions will look almost similar. So with this panic, there's a likelihood of many of these hand, foot and mouth disease cases being referred by our centers. That's one issue. Second question is, okay, we all know very close contact is the this is transmitted through very close contact, and we know sexual route is one of the transmission, even though it's not a classical STD. So should we have any strategy to sensitize the TI projects like MSM and CSW projects, because they also should be aware of the disease, because we know many countries like you mentioned, Europe and UAE are having most of the cases in people who had sexual contact. So should we be careful about that too? That too.
No. That is actually regarding the hand, foot, and mouth disease. As you rightly said, means it is a very close DD of monkeypox. So the key is the key here is going to be the epidemiological link, and hopefully I think that we may be able to contain the monkeypox epidemic. Suppose the number of cases starts rising in Kerala due to some reason, then it might become when epidemiological link goes out of question, then this is likely to become a big headache. How to differentiate this HFMD versus monkeypox? Relying on the punctum and all to differentiate may not be possible for all the doctors and all, because palms and sores, and that is how we differentiate chickenpox and monkeypox, with palms and sores will be affected in HFMD like that. It's a close DD, but as of now, the epidemiology link is likely to help us. Regarding the second aspect, like it's being spread in the MSM communities in Europe and all, that's true. Regarding the sensitization to that community, that actually we do have time, sir. We can study the transmission dynamics in the state. What is going to happen here? As of now, we are having only one case. What you've done is actually sensitizing the dermatologist, because in the West also, majority of the cases are going to the dermatologist, because following this contact, they're developing only proctitis and anogenital lesions. So anogenital lesions, they are presenting to the dermatologist, and that is why WHO has said that now majority of the presentation is atypical. In this case, our case is actually classical presentation, very difficult to miss. But majority of the cases are not going to be like this. They may be having only a few lesions in the anogenital region. They are likely to go to the dermatologist. So the sensitization of the dermatologist is actually the first on the list. And then if there is an increase in number of cases in a particular community like that in the state, then we will think about orienting them, sir. We'll go in a step-by-step fashion.
Thank you.
Thank you, sir.
Sorry, I was on mute. Sorry, actually there are few questions in YouTube chat also. One is to Dr. Nikhilesh. Why we are taking so many samples? Will it increase the risk of transmission? That is one question.
I think I can answer that. Okay, because I have been involved in sample collection in our case. The thing is that if you want to confirm the diagnosis, the sampling multiple site is important. So multiple, in our case we got positivity from all sites, blood, urine, oropharyngeal, nasopharyngeal, as well as the multiple the pustules that we swab. But it need not be the case. That is why they insist on multiple things. And you're taking the same precautions. If you're taking one swab or a double swab, you're taking the same precautions. So it should not be a major problem. So because there is no airborne this thing involved, so there is no need for a PAPR mask and all those things. So I don't think it is a problem. So we need to increase the yield. Because if we get the diagnosis, then actually we know what to do. But suppose clinical diagnosis is monkeypox and your result is coming as negative, then you are in a fix.
Yes, ma'am. As sir said, from a lab point of view, we always try to get a sample with the maximum yield. So if more samples are there, the yield will be more. So we can diagnose it better. The detection rate will be high.
Thank you.
And one thing is actually, the thing is about de-roofing the lesion, scraping the base and aspirating the fluid and all. Seeking the help of a dermatologist definitely help. Because I think that our sample collection was done with the help of the dermatologist, and they did a wonderful job because whatever lesion they scrapped came out positive for the virus. So all of us may not be that much trained in de-roofing the lesion and all those things.
Thank you, sir. Actually, will taking COVID vaccine offer any immunity to monkeypox? That is a repeatedly asked question in the chats.
COVID vaccine will give any immunity to monkeypox? No, it won't give any immunity to monkeypox.
Yes, since it is being repeated, I thought I'll just read it out.
And another question, is there any correlation between COVID-19 vaccine and monkeypox infection? Actually, there is no correlation between COVID-19 vaccination and monkeypox infection. Okay.
Is there any chance of transmission during postmortem? That is also a question which came in YouTube chat.
Actually,
there is a chance for that.
Definitely there is a chance because this orthopox virus can persist for a period of time. That's what we already said. So in that case, there is a chance, and we need to take all the precautions that is to be taken. There is no airborne transmission, so we need to take all the droplet as well as the contact precautions while doing autopsy.
Or this is all from my side. Anybody having questions, please go ahead, ask.
There is another question. Chance of spread fecal, oral, or via urine. Actually, urine we have identified the virus. In our case, also urine PCR is positive. The fecal-oral route has not been described till now. So the urine is a possibility. And regarding the sexual contact, it is not sexual transmission. It is actually the intimate skin-to-skin contact which occurs during sexual activity. That is the reason why it is spreading in the MSM community. It's not because of sexual transmission.
Anybody else having any questions? How much transmission risk occurs through fomites and objects?
Actually, through fomites, the transmission can occur. So there is definitely a risk, and we need to take the protection for that. It's actually the basic concept of contact precautions.
If we are having no more doubts, shall we go?
Sir, I am having a doubt. Sir, it's regarding the quarantining of the patient, sir. Actually, what kind of quarantine do you advise? Whether it is home quarantine or 100% institutional quarantine?
Actually, the national guidelines do not mention the quarantine per se. What they say is that the contact should be monitored for 21 days. Symptom surveillance should be done. Since it is the first case in the state, in the country, the high-risk contacts, that's the family contacts, they are being quarantined. The high-risk contacts, the family contacts are being quarantined. And if we can ensure room quarantine at home, then that should be enough. But 2 of them are being quarantined in the hospital.
Okay, thank you, sir.
Anybody else?
Dr. Arvind, I just want to ask you, Dr. Titus here. What are the chances of this becoming a epidemic or a pandemic, because COVID-19 also started with one case from Wuhan or Italy and became a pandemic. So what are the chances that this would magnify?
As of now, sir, the majority of the cases, out of the 6,000 cases from January 1 to July 4, the majority of them are having some sort of a link to this MSM community. So that is how it's spreading in the Europe and all. And since there is no airborne transmission per se, you need to have very close skin-to-skin contact or face-to-face contact. So, and WHO is actually looking at. They have not declared it as a concern or anything. They have not declared. They have not declared it as a pandemic. But then there are concerns that the virus has adapted more to the humans. Humans, even though humans are incidental hosts, the adaptation has occurred in this orthopox virus. That concern is always there, and whether it will become a problem in Kerala is too early to say that. So we can't say that it won't become a problem, but then the data till now shows that it's actually spreading in particular communities like that. The secondary attack rate, even in families, households, is only around 8%. As airborne transmission is not involved, the rapid multiplication of cases also is not expected.
നമ്മൾക്ക് ശരിക്കും പറയുകയാണെങ്കിൽ ഇത്രയും കേസുകളിൽ ഒരു മെയ് മുതലാണല്ലോ കേസസ് കൂടുതലായിട്ട് നമ്പേഴ്സ് കൂടുന്നതായിട്ട് കാണുന്നത്. ഈവൻ ജൂൺ 17 കഴിഞ്ഞിട്ട് 22 വരെയുള്ള സമയത്ത് പോലും 1000-നേക്കാൾ കൂടുതൽ കേസസ് ആയിട്ട് പറയുന്നത്.
മാഡം മങ്കി പോക്സ് അല്ലേ മാഡം?
മങ്കി പോക്സ് തന്നെ.
അതെ മാഡം, ഇത് ആക്ച്വലി യൂറോപ്പിലാണ്, മറ്റേ സ്പെയിനിലും പോർച്ചുഗലിലൊക്കെയാണ് റാപ്പിഡ് റൈസ് വന്നത്. അതെല്ലാം തന്നെ ഈ ചില റേവ് പാർട്ടീസുമായിട്ട് ബന്ധപ്പെട്ടുണ്ടായിരുന്ന കോൺടാക്ട്സ് ആണ്. അവർക്ക് കോൺടാക്ട് ട്രേസ് ചെയ്യാൻ പറ്റില്ല, ഒത്തിരി പേര് ഇൻവോൾവ് ആയതുകൊണ്ട് ഉണ്ടായതാണ്. ഈവൻ മാഡ്രിഡിൽ മോർ ദാൻ 1000 കേസസ് ഉണ്ട്. അതെല്ലാം പെർട്ടിക്കുലർ കമ്മ്യൂണിറ്റീസിലാണ് ആക്ച്വലി വന്നത്. എന്താണ് WHO റീസൺ സ്റ്റേറ്റ്മെന്റ് ഓൾസോ they have said that that is the reason why it is spreading in certain communities like that. Usually WHO അങ്ങനെ പറയാറില്ല, കാരണം നമ്മൾ നോക്കുമ്പോൾ ഈ കേസസില് മീൻസ് 99% മെയിൽസ് ആണ്. അപ്പൊ അവരുടെ എല്ലാം തന്നെ മീൻസ് ആക്ടിവിറ്റീസ് ഒക്കെ നോക്കിയിട്ടാണ് അങ്ങനെ പറഞ്ഞത് മേഡം. അങ്ങനെയാണ് പെട്ടെന്ന് റൈസ് വന്നത് ഈ പോർച്ചുഗലും സ്പെയിനും കാരണം. പിന്നെ വേറൊന്ന് മാഡം, ഈ പറയുന്ന കേസസ് എന്ന് വെച്ചാൽ ഇപ്പൊ നല്ല സർവൈലൻസ് സിസ്റ്റം ഉള്ള സ്ഥലങ്ങൾ ഐഡന്റിഫൈ ചെയ്യും. ഇതിൽ വളരെ കുറച്ച് ലീഷൻസ് ആയിട്ടാണ് മെജോറിറ്റി ഓഫ് ദ കേസസ് പ്രസന്റ് ചെയ്തിരിക്കുന്നത്, ഏനോജെന്റൽ ലീഷൻസ് ഒക്കെ ആയിട്ട്. സോ ഐ തിങ്ക് ഇറ്റ് വിൽ ബി misdiagnosed or it may not be diagnosed as monkeypox. That can also happen, right? So in our patient also, a patient in a contacts under the confirmed cases allalla, suspected cases are. Those cases are not being picked up in other countries. That is also an issue.
ഓക്കെ സർ, നമ്മളുടെ കേസസിനും ലീഷൻസ് വളരെ കുറച്ചില്ല. നമ്പർ ഓഫ് ലീഷൻസ് വളരെ 50-ൽ താഴെയാണെന്നാണല്ലോ സാർ പറഞ്ഞത്.
25-ൽ താഴെയാണ് മാഡം. പക്ഷേ ഇത് കുറച്ച് ക്ലാസിക്കൽ പ്രസന്റേഷൻ ആണ്, മിസ് ചെയ്യാൻ കുറച്ച് പാടാ നമ്മുടെ കേസ്. ഇങ്ങനെ വരണമെന്നില്ല മാഡം. ഇത് മീൻസ് ഇങ്ങനെ വരണമെന്നില്ല.
മനസ്സിലായി സർ.
ഇത് പാംസിൽ ഉണ്ടായിരുന്നു, മറ്റേ ലീഷനിൽ മറ്റേ പങ്ക്ടം ഉണ്ടായിരുന്നു. ഈ that punctum and dots are not seen in all cases, madam. This is actually the classical textbook description of monkeypox പോലെയാണ് നമ്മുടെ അടുത്ത് വന്നത്. എങ്ങനെ വരണമെന്നില്ല. And patient had lipedema also. Lipedema ഒക്കെ വന്നു കഴിഞ്ഞാൽ വാരസെല്ല സോസ്റ്ററും ഒക്കെ ഔട്ടായി. നമുക്ക് അധികം DDs ഇല്ല മാഡം. അപ്പൊ ഇത് ആക്ച്വലി ഇസ് വെരി ഈസി കേസ് ആണ്. പക്ഷെ ഇങ്ങനെയല്ല പ്രസന്റ് ചെയ്യുന്നത്. വളരെ ഫ്യൂ ലീഷൻസേ കാണത്തുള്ളൂ. ഏനോജെന്റൽ ഏരിയയിൽ മാത്രമായിട്ടായിരിക്കും വരുന്നത്, അല്ലെങ്കിൽ പെനിസി ഒരു ലീഷൻ ആയിരിക്കാം. Then it becomes very difficult. അങ്ങനെ ആകുമ്പോൾ the link becomes very important. The contact history etc. becomes very important.
Sir, a hypothetical case, if Kerala is having more cases, and what will be our strategy of vaccination? That was one question.
Actually means നമ്മുടെ കയ്യിൽ വാക്സിൻ ഇല്ല, അതാണ് ഒരു മെയിൻ തിങ്. സപ്പോസ് the cases exponentially ഒന്നും കൂടത്തില്ല. അങ്ങനെ കൂടി വരികയാണെങ്കിൽ we have to means request central government. Suppose the disease vulnerable group, immunocompromised അങ്ങനെയൊക്കെ ഒരു പോപ്പുലേഷനിലോട്ട് പോകാൻ ചാൻസ് ഉണ്ടെന്ന് തോന്നുകയാണെങ്കിൽ probably we have to request. But the thing is that even in USA, they are not having enough stock of this vaccine. And that is the issue. Why does it spread more in MSN communities? Actually, because of the skin to skin contact is occurring. And why that community means it just observed that the more cases are being reported in the West from that community. The reason is actually the skin to skin contact. After how many days a patient can donate blood in case if cases increase? As of now, the only thing I can say is the national guideline says that you can do it after 21 days. In 21 days, you cannot do that. Other observation period, positive patient, when the patient can donate, it has to be after 3 months only.
ഇനി ആർക്കെങ്കിലും ചോദ്യങ്ങളുണ്ടോ? വേറെ ചോദ്യങ്ങൾ ഇല്ലെങ്കിൽ നമുക്ക് കൺക്ലൂഡ് ചെയ്യാമോ മാഡം? 2 മണിക്കൂറായി. മാഡത്തിന്റെ നെറ്റ് കുറച്ച് വീക്ക്.
ദിവ്യ കൺക്ലൂഡ് ചെയ്തോളൂ.
ഓക്കെ മാഡം. ഈ ഒരു സെഷൻ വളരെ ഏർലി ആണെന്നറിയാം. പക്ഷെ എന്നാലും അതൊരു വളരെ ഈ അത്യാവശ്യമാണെന്ന് തന്നെ നമുക്ക് കരുതേണ്ടതുണ്ട്. കേസ് കൂടുതൽ ഉണ്ടാവാതിരിക്കാം. എന്നാലും പുതിയൊരു രോഗമാണ് നമ്മുടെ നാട്ടിലേക്ക് വന്നിരിക്കുകയാണ്. അതിനെക്കുറിച്ച് നമ്മൾക്ക് പ്രാഥമികമായി കുറച്ച് കാര്യങ്ങൾ അറിയേണ്ടതുണ്ട്. Probably in coming days, we'll get more familiar with the diagnostics, treatment and all. നമുക്ക് കമ്മിങ് ഡേയ്സിൽ കൂടുതൽ അപ്ഡേറ്റ്സ് ഉണ്ടെങ്കിൽ കൂടുതൽ സെഷൻസ് ഉണ്ടാവും. അതിന്റെ എല്ലാം വിവരം ഇത്തരം ത്രൂ ദ പ്രോപ്പർ ചാനൽ സിസ്റ്റത്തിലുള്ള പ്രോപ്പർ ചാനലിലൂടെയും നമ്മളുടെ അവൈലബിൾ ഹെൽത്ത് വർക്കേഴ്സിൻ്റെതായിട്ടുള്ള വാട്സ്ആപ്പ് ഗ്രൂപ്പ്സിലും ഒക്കെ ഉണ്ടാവും. ഇന്നത്തെ ഈ സെഷൻ more than 1000 participants ഉണ്ട്. To be precise, around 1200 participants ഉണ്ടായിരുന്നു. 1000 in the YouTube and around 200 in the YouTube 1000 in the Zoom and around 200 in the YouTube channel. ഇതിനെ കുറിച്ച് ഇത്രയും ചുരുങ്ങിയ സമയത്ത് എനിക്ക് നേരത്തെ നമ്മുടെ DME സാറ് പറഞ്ഞതുപോലെ ഹോസ്പിറ്റലിലെ എല്ലാ തിരക്കുകൾക്കും ശേഷം നമ്മളോടൊപ്പം ചേർന്ന് ഈ സെഷൻ കൈകാര്യം ചെയ്യാൻ നമ്മളോടൊപ്പം വന്ന ഡോക്ടർ അരവിന്ദ് സാറിന് ആരോഗ്യ വകുപ്പിലെ എല്ലാ ജീവനക്കാരുടെയും പേരിലും നമ്മുടെ ഹെൽത്ത് കമ്മ്യൂണിറ്റിയിലുള്ള എല്ലാവരുടെയും പേരിലും നന്ദി രേഖപ്പെടുത്തുന്നു. അതോടൊപ്പം ഡോക്ടർ നിഖിലേഷ് മേനോനെ ഈ ഒരു സെഷൻ എന്തായാലും ഇതിന്റെ ഇന്നോവേറ്റബിൾ പാർട്ടാണെന്ന് നമ്മളോട് സജസ്റ്റ് ചെയ്തതും അരവിന്ദ് സാറ് തന്നെയാണ്. അതും വളരെ ഷോർട്ട് നോട്ടീസിലാണ് ഡോക്ടർ നിഖിലേഷിനെയും അറിയിച്ചത്. ഹി വാസ് ഓൾസോ very much willing to take the session, came up with the nice slides and all the informative things. Thank you, Dr. Nikhilesh also. ഇതിനെ വളരെ ടൈംലി ആയിട്ട് നമ്മളോടൊപ്പം ഇത് നടത്തണം എന്നുള്ളൊരു നിർദ്ദേശം, ഒരു അഡ്മിനിസ്ട്രേറ്റീവ് ഡെസിഷൻ എടുത്തത് നമ്മുടെ അഡീഷണൽ ഡയറക്ടർ ട്രെയിനിങ് ആൻഡ് അഡ്മിനിസ്ട്രേഷൻ ഡോക്ടർ റീന മാഡം ആണ്. ഇതിനോടൊപ്പം ചേർന്ന നിങ്ങൾക്ക് ഓരോരുത്തർക്കുമാണ് കൂടുതൽ നന്ദി പറയേണ്ടത്. കാരണം like in the time of COVID, when we started with our COVID wave, whenever the COVID wave started hiking and coming up, all of you were totally interested in coming up with sessions, asking a lot of doubts. Every day there was sessions regarding post-COVID session, post-COVID complications, COVID in children, COVID in ICU and whatnot. അപ്പോൾ ഈ ഓട്ട് ടൈംസിൽ നമ്മളോടൊപ്പം അറിവ് ഷെയർ ചെയ്യാൻ ചേർന്ന ഓരോരുത്തർക്കും ആരോഗ്യ വകുപ്പിന്റെ പേരിലും ഈ ഹെൽത്ത് കമ്മ്യൂണിറ്റിയിലെ ഓരോരുത്തരുടെയും പേരിലുള്ള നന്ദി അറിയിച്ചുകൊണ്ട് നമുക്ക് ഇന്ന് അവസാനിപ്പിക്കാം. താങ്ക് യു സാർ. അപ്ഡേറ്റ്സ് ഉള്ള മുറയ്ക്ക് നമുക്ക് വീണ്ടും തുടരാം. താങ്ക് യു.
Thank you all. Good night.
Good night. സെഷൻ എൻഡ് ചെയ്യാം ശ്രീജിത്ത്. താങ്ക് യു ശ്രീജിത്ത്.